So, Nena, over to you.
Good evening. Good evening. Can you hear me?
Good evening. Yes, good
Okay.
evening.
Okay. Good evening, presidents of EMSON, professors, consultants, colleagues. I'll be presenting on behalf of the Southeast Zone of EMSON on toxic multinodular goiter. My name is Dr. Kuri Nena. So these are my outline, case summary, introduction, anatomy, physiology, epidemiology, clinical features, management. For the case summary, a 38-year-old married businessman referred to our clinic by the cardiology unit UNTH in October 2024. The diagnosis of heart failure secondary to dilated cardiomyopathy following complaints of recurrent exertional dyspnea, bilateral leg abdominal swelling, bilateral leg and abdominal swelling, palpitation, PND, orthopnea, fatigue, weight loss. A 24-hour ECG had revealed a tachyarrhythmia, and he was asked to do a thyroid function test, which was suggestive of hyperthyroidism, hence the referral to our unit. Endo visit, anterior neck mass, palpitation, hyperdefecation. During the endocrine visit, he had anterior neck mass was found, palpitation, insomnia, intolerance, restlessness. He had also progressive weight loss, all approximately of a year duration. He weighed 58 kg and was 1.72 meter tall. He was also on HART, prescribed 6 years ago, earlier for retroviral disease. Tabs, dolutegravir, lamivudine, and tenofovir he was on that. He was prescribed. He had but no significant alcohol use. He had no known family history of thyroid disease. Thyroid function test revealed free T3 of 45.8 for PMO, which was markedly elevated, free T4 of 79.77 PMO, and then TSH of less than 0.005, suppressed as well. And then 24-hour ambulatory blood pressure monitoring revealed 24-hour average BP of 103/64 millimeter mercury daytime, the blood pressure average of 104, and diastolic 62 millimeter mercury. The night average of blood pressure average of 100, the systolic and diastolic 57 millimeter mercury. The rest ECG revealed sinus rhythm, heart rate 91 beats per minute, and the first degree AV block, T wave inversion in the lateral leads. 24-hour Holter ECG revealed total heartbeat of 153027, maximum heart rate of 172, minimum heart rate of 80. and episodes of sinus tachycardia, episode of SVT, non-SVT, ventricular ectopics, bigamy and trigeminy. Neck ultrasound scan revealed both thyroid gland lobes were enlarged and diffuse heterogeneously, hypoechoic appearance with an intact and regular capsule. The multiple tiny cysts are seen bilaterally. Echocardiography, all chambers were dilated, no left ventricular hypertrophy, global hypokinesia, left ventricular ejection fraction 25%, and fractional shortening of 12%, with poor right ventricular systolic function and a tricuspid annular plain systolic excursion of 14 millimeter, with spontaneous echo contrast in all chambers. He was placed on the following: the tab spironolactone 25 milligram BV, tab digoxin 0.25 milligram daily, tab bupiral 25 milligram BD, tab dapagliflozin 5 milligram daily, tab dabigatran 150 milligram BD, and tab bisoprolol 5 milligram daily, tab carbimazole 30 milligram BD. A repeat thyroid function test was done on the 5th of May 2025, where free T3 revealed 6.48 pmol and the free T4 14.64 pmol, and then TSH less than 0.024. In May 2025, still on the same dose of carbimazole, his thyroxine level had normalized and had thyroidectomy. He's scheduled for repeat thyroid function test and follow-up in 6 weeks. Histopathology report section arranged into nodules by delicate fibrocollagenous bands. The follicles are of different sizes and shapes. The follicular epithelium is variable, occasionally cuboidal and occasionally columnar. Cholesterol crystals and siderophages are seen. Diagnosis of multinodular goiter was made. So as way of introduction, toxic multinodular goiter is one of the most commonest causes of hyperthyroidism. Arises in multinodular goiter of long-standing and is as a result of several pathogenic factors. Toxic multinodular goiter represents significant public health concern due to its impact on cardiovascular health, metabolic balance, quality of life, especially in resource-limited settings. It can induce or exacerbate cardiovascular disorders, including atrial or ventricular arrhythmias, atherosclerotic vascular disease, dyslipidemia, heart failure, thereby contributing to a higher risk of premature morbidity mortality. It has also been implicated in dilated cardiomyopathy and myocardial infarction. It often occurs in older adults and tends to have more insidious onsets and symptoms. The anatomy of the thyroid gland. The thyroid gland is located at the lower part of the front and sides of the neck, extends from an oblique line of the thyroid cartilage, fifth to the sixth cervical tracheal ring, and fifth to sixth tracheal ring, lie against this C5, C6, C7, T1, and consist right and left lobes joined by the isthmus. So that's the isthmus, that's the left lobe, right lobe of the thyroid gland, the cricoid cartilage, the isthmus, the thyroid cartilage of larynx. A third pyramidal lobe may project upwards from the isthmus. Arteries, superior and inferior thyroid, the arteries, the superior and inferior thyroid arteries, and therefore the veins, superior, middle, and inferior thyroid veins. The thyroid develops from the endoderm of the floor of the primitive oral cavity in the region of the future foramen cecum and ultimobrachial body. That's a normal thyroid. It's a multinodular thyroid. That's a nodule, and then thyroid with multiple nodules. The physiology. The hormone production, the physiology for the functions, the commonest hormones, the hormone production is T3 triiodothyronine, T4 thyroxine, and the calcitonin from the parafollicular B and C cells. For the function, the T3, T4 regulate metabolism, influence growth, development, affects the heart rate, temperature, and weight. Calcitonin lowers blood calcium levels by inhibiting resorption. Daily requirement of iodine, about 100 to 200 per day, is thyroid gland contains about 9% in thyroid gland, while 80% are being excreted. Sources are salt, bread, eggs, milk, and fish. The synthesis and storage involves the iodine tryptase synthesis, secretion of the thyroglobulin, oxidation of the iodine, organoification, thyroglobulin, and coupling reaction with storage secretion. These usually occur in the follicular and the columnar cells. But the hormone regulation is controlled by the hypothalamic pituitary axis. The hypothalamus releases the TRH, thyrotropin releasing hormone. The pituitary releases the TSH, thyroid stimulating hormone. And then the TSH stimulates the thyroid to produce the T3 and the T4. For the pathogenesis of the thyroid multinodular goiter occurs in patients with long-standing euthyroid goiter. Two hallmarks of the disorder, functional autonomy, evolve over time. The increase in the extent of autonomous function causes the disease to move from non-toxic to toxic phase. Somatic mutation in the TSHR gene first demonstrated in toxic adenoma. Only about 60% have been demonstrated in toxic multinodular goiter, and individual mutations appear to differ from nodule to nodule. Only a very few have the G protein mutations, cause constitutive activating adenylate cyclase. This results in TSH-independent activation of thyroid hormone synthesis in certain nodules and loss of TSH regulation. Hyperthyroidism, as small nodules become autonomous, thyroid hormone production exceeds the body needs. There are many nodules with autonomy of determined cause. So, summary of the pathogenesis. So, the iodine deficiency of thyroid stress, the TSH stimulates follicular hyperplasia. So, thyroid stress, and we can call nodular transformation, then mutation, somatic mutations activating the autonomous TSH independent hormone production, toxicity and suppression, excess T3 and T4 suppression of TSH. Epidemiology. Global epidemiology of the toxic multinodular goiter is more prevalent in iodine deficient regions such as the sub-Saharan Africa, South Asia, parts of South America. In areas with long-standing deficiency, 5 to 30% of nodular goiters may be fatal. A meta-analysis of 59 African countries, the studies by Adegoke, Aziz, and Oguremi et al. Noted that toxic nodular goiter and toxic multinodular goiter accounts for a significant proportion of hyperthyroidism cases in sub-Saharan Africa, particularly in iodine-deficient areas like Nigeria. The study reported a higher prevalence of toxic multinodular goiter in older populations compared to Graves' disease. It's more common in females with a female-to-male ratio of 5:1. Risk factors have age, common in people older than 50 years, 50 and above, but our index patients in the case summary was 30. Was in his 30s. Commoner in females, gender, and iodine deficiency area. We have genetic and radiation exposure, especially head to neck, dietary deficiency, such as low iodine, selenium, excess iodine intake, sudden high intake of contrast agents, goitrogenic foods such as cassava, cabbage, broccoli, soy, smoking. Smoking has been found to be a very big risk factor, and our patients had 12 pack years. So smoking has what we call for smoking, thiocyanate induces, thiocyanate contained in smoking induces iodine disruption. Is a major component of cigarettes, and it inhibits iodine uptake. By some drugs too can be a risk factor for a patient was on after starting ART immune system. For the management, we have clinical evaluation, investigation, and treatment modalities. For the clinical evaluation, history, biodata, chief complaints, history, precipitating factors, the past medical history, medication, family history, social history. So for the history, we already, from our case review, found that the patient had a neck mass for over a year, and he was in his 30s. He was referred by the cardiology team. So most times these patients present with cardiac problems, either heart failure, arrhythmias. So he was referred from the cardiologist. So most times they present to the cardiologist before us, most cases. Precipitating factors, diets, like we already mentioned, for in his own case, and then even smoking and other things, the iodine deficient areas, past medical history, if he had had surgery in the past, or if he had had any family history amongst them, family history of thyroid cancers or autoimmune problems, or just endemic goiters, social history, any history of alcohol, and then smoking, like we already mentioned in smoking, that the cigarette contains thiocyanate that inhibits iodine uptake, competing with the iodide, and he had 12 pack years of smoking. I want to do review of systems. He had dyspnea, PND, orthopnea, bilateral leg swelling. So he had presented with more cardiac features, and he had hyperdefecation. If through the and then tremors, he was tremulous. He had other heat intolerance and all of that. For the physical examination, he was anxious, restless. Most time they present with sweaty, thin body habitus, body mass, hair thinning, hands, palm erythema, onycholysis. Next examination and inspection. We had obvious thyroid mass, though not so obvious. Examined by palpating and auscultating the patient. The thyroid gland was firm, irregular, palpable thyroid nodules, but it wasn't distinctively enlarged in our patient. So a thyroid ultrasound will confirm the diagnosis. In toxic multinodular goiters, most times the goiter might not be distinctively enlarged on inspection. So most times you have to on ultrasound, that's when you confirm that it's actually a multinodular goiter. So this is our index patient, of course, with his permission. You can see the tiny habitus and WHO grading of goiter: grade 0, no visible or palpable goiter; grade 1, palpable goiter, but no visible or normal position; grade 2, visible goiter. Our patients had grade 2. So still on the physical exam, cardiovascular symptoms always predominate in toxic multinodular goiter. Tachycardia may be irregular if atrial fibrillation is present, bounding pulse, elevated systolic BP with wide pulse pressure, signs of heart failure, fine neurological fine tremors, hyperreflexia. There are usually no eye signs in toxic multinodular goiter. That's what differentiates it from Graves. Investigation, laboratory evaluation, the thyroid function tests, thyroid autoantibodies, liver function tests, the SUCR, blood glucose, lipid. You have to do a baseline because of before you commence them on the anti-thyroid medication or even start treatment. So we first of all get the thyroid function test, and then they do the other baseline, whole blood counts, and then complete blood counts, and then prepare the patients, even doing coagulation studies, in case patients will be worked up for surgery. Imaging, thyroid ultrasound, neck x-ray, chest x-ray, thoracic inlet x-ray, CT, MRI. If this patient also has features suggestive of compression, dysphagia, dysphonia, so MRI, CT can also help. And radioisotope thyroid scan, electrocardiogram, and echocardiogram. So this is the radioactive iodine uptake scintigraphy of. So for the normal patients, it's uniform uptake. Graves' disease, you have for the Graves' disease, you have diffuse uptake. And then for the toxic multinodular, you have heterogeneous, not diffuse, heterogeneous uptake, where you have patchy uptake. Because of the multinodular goiter, you can see some patchy areas, and then for the toxic adenoma, you have a focal uptake of the radioactive iodine. Other areas are suppressed. So for the microscopic histology, for the histology, you have thyroid follicles of varying sizes. They are not uniform. In normal histology, their follicles are uniform, but in toxic multinodular goiter, the follicles are varying sizes, as you can see. And then the follicles are lined by hyperplastic stratified columnar epithelium with intraluminal papillary tuftings. Then colloid is scanty, watery with scalloped appearance. Blood vessels along with lymphoid aggregates. So in the histology of expected to see blood vessels, hemorrhage, lymphoid aggregates, colloid is, and then the colloid is usually scanty with a scalloped appearance. Scalloped appearance is just this white thing here. So the treatment modalities, you have anti-thyroid drugs such as carbimazole, metimazole, propylthiouracil, beta blockers, propranolol, surgery. Total thyroidectomy is gold standard. The propylthiouracil is preferred in pregnant women, especially in their first trimester. And additional treatment options are imaging guided percutaneous ethanol ablation, radiofrequency ablation, only used when standard modalities of radioactive iodine therapy, surgery, and antithyroid drugs are contraindicated. Radioactive iodine therapy, absolute contraindication in pregnancy, and of course, PTU is preferred in pregnant first trimester. So, still on treatment, in 2022, by F. Aziz et al. Conducted a study in Research Institute for Endocrine Sciences, Sahid Beheshti, University of Medical Science, Tehran, found out that long-term use of methimazole treatment rendered 96% group of patients euthyroid when compared to radioactive iodine treatment group that had 41% and then 22% persistent hypothyroidism, 41% hypothyroid and 22% persistent hypothyroidism. So he found out that methimazole treatment rendered a group of patients euthyroid as compared to radioactive iodine treatment. So emerging trends in toxic multinodular goiter, you have the gene therapy targeting somatic, this is a future direction, targeting TSHR mutation to restore normal thyroid function, recombinant human TSH in an RH, pre-treatment to enhance ray uptake, and then reducing required doses by 30 to 50%. Precision medicine, integrating biomarkers, AI-driven dosing models, and immunotherapy for tailored treatments. Endoscopic thyroidectomy in toxic multinodular goiter. Such as the transoral endoscopic thyroidectomy, vestibular approach, and axillar bilateral breast approach. These are scarless procedures that allow access without visible neck incision. Ideal for patients with cosmetic concerns, like the Anwongs et al. In Thailand, 2016 study.
Okay, good evening, all. I was briefly logged out, so but I'm back on now. Thank you so much, Dr. Korea, for the lecture. Can you all hear me?
Yes.
Okay, all right. So I will just add the learning points. The patient in question has done really very well. He has come for the 6 weeks appointment. However, we are yet to get the repeat thyroid function test. But when he came, he had gained some weight and was in excellent spirits. He was weighing 58 kg when he saw us the first time. His weight now is 76 kg by the time he saw us last. and all the arrhythmias or the palpitations and tachycardia that he was experiencing, they had all stopped. Well, this particular case that we presented explains why we need a multidisciplinary approach in the management of these patients. Like the speaker mentioned, that most times they present with the cardiac complications. And really, one of the differences sorry about the network problem. So by the time they present, they may be presenting with the cardiac complications. Well, another thing of note is that, like the speaker said, that in toxic multinodular goiter, that what we have is nodules that become autonomous in function. Now, because the nodules become autonomous in function, it becomes very difficult for them to actually go into remission, as we have in Graves, that by the time you bring in medical management for Graves, that most of them will go into remission. While that of toxic multinodular goiter, they Okay, so the other difference between Graves and toxic multinodular goiter is that mostly in Graves, we have the orbitopathy, we have pretibial mixed edema, and acropathy, while in toxic multinodular goiter, we do not have such things. And then let's also talk about subclinical hyperthyroidism, because this comes up a lot of times. Mostly, the subclinical hyperthyroidism does not require treatment. Largely, they are monitored. However, patients are advised not to take excessive, like supplements that contain excessive iodine, and not to use, if they want to go for any imaging, not to use contrast that contain iodine. However, In the elderly ones that have subclinical hyperthyroidism and people that present with osteoporosis or with cardiac involvement, atrial fibrillation, heart failure, and other ones, treatment is indicated in these ones. Then another thing I want to point out is that in the medical management, that proprietary actually is a second line drug in the management of hyperthyroidism. Reason being that it has more toxicity compared to carbimazole that we readily use. It causes a lot of liver toxicity, and there has been studies that reported incidences of liver toxicity with some of the patients leading to mortality in some of the patients and liver transplant in some others. And this is why before we commence these drugs, one will need to do a liver function test and a full blood count, of course. And however, we have certain exceptions, like the speaker also mentioned, in first trimester of pregnancy, that one will have to use a proprietary. And then, of course, in people that are allergic to carbimazole as well. Then there's also a monoclonal antibody that is now in clinical trials for the management of hyperthyroidism. That's batoclimab. However, this is indicated more for Graves' disease, because what it does is to potentially reduce thyroid autoantibodies. So if there are comments or questions, we can ask our questions or make our comments. Thank you. Hello? Hello? Can you all hear me?
Yes, please.
Okay, so if anyone has a comment or a question, we'll be glad to hear them. Or any learning points.
Hello,
So
sir.
no comment. Okay, yeah.
Good afternoon. I went down to the southeast zone, right?
Yes,
I'm Dr.
Southeast.
Ajani from Southwest. Unfortunately, the network did not allow me to fully get the information presented. But I think I heard the part where the presenter mentioned that the index case was of toxic multinodular goiter, that the goiter was not really feasible, but ultrasound detected despite the myriad of symptoms the patient had. I just want to have from your summary, maybe to just make some of us catch up, that what is your recommendation generally for the care of patients with toxic multinodular goiter and resource-poor setting like our own? And are you recommending any area of research that can help us to improve the care too in the nearest future? Thank you, sir.
Okay, any other question? Any other question or comment? Okay, let me attend to this question. The unique thing about toxic multinodular goiter is the autonomous hyperfunctioning of the nodules. And once there's a nodule or nodules that are hyperfunctioning, they will exacerbate the thyroid hormones. And this is not very responsive to the medical treatment that we employ. So the mainstay for management is, well, in this our environment, is surgery. And most times, once you even speak with the general surgeons, they will tell you that they do not respond to the medical treatment. And most of the ones that I have attended to, or have most of the patients with toxic multinodular goiter that I've attended to, none of them ever got remission. So most times is to make them euthyroid, like in this particular case, and then do surgery, surgical resection. It can be subtotal thyroidectomy, near total thyroidectomy, or total thyroidectomy, as the case may be. This index patient had a subtotal thyroidectomy. So by the time he got the surgery, we withdrew the anti-thyroid medications that he was on. Well, we are waiting the result of the thyroid function test to see if he will require levothyroxine supplementation or not. So I hope I was able to answer your question.
Thank you. Yes, but is there any real research gap that I think we can, based on your experience in your center, especially concerning the toxic multinodular goiter, that I think is feasible for the country?
Well, surgery already, I believe, is not that expensive, seeing that if it is a total, well, subtotal one, yes, some of them may eventually develop hyperthyroidism again. But I'm trying to say that since we already have surgery, which is very efficient, and we can do that, I don't know whether there's any other cheaper method that we can adopt or we can do researches in.
Not really. Like the presenter mentioned, gold standard is surgery. And she told us about the benefits of total thyroidectomy. So I'm just wondering that maybe from your experience, you may recommend us looking at the profile of patient managed so far, the outcome of care in those that have total thyroidectomy, partial thyroidectomy,
Okay.
or selective nodular removal, and compare and contrast and see what can really work for a patient. Like you're saying now that this patient, until you review biochemically at the next visit, we may not be able to say that it's euthyroid or hypothyroid. But
Okay.
I believe
Okay,
that
I understand what you mean
going
now.
forward, thank you.
Yeah. So going forward, actually, yes, I think it will be necessary for us to do a research in that and compare the different cases, like the outcome for subtotal, near total, and the total. So to know which one will eventually be cheaper, because if it is total thyroidectomy, this person definitely will need levothyroxine for the rest of his or her life. And so we need to know the percentage of people after subtotal that could develop hyperthyroidism again. This would be actually well, that is what we need to do to be able to say that this is the best approach to adopt in our patients. Thank you, sir.
Thank you, and congratulations to the whole team for hosting us this weekend.
Thank you, sir. So any other comment or question?
Good evening. Good evening to the presenter and the supervising Zoom. It was a good presentation. Am I audible, please?
Yes, you are.
Okay. Yeah. So just a few comments. The first comment, which you and Dr. Ajani are trying to address. I was actually surprised that the patients had total thyroidectomy. I was
Not
expecting
total,
that since it is.
subtotal. Subtotal.
Oh, okay. Maybe it was a slip of tongue when she was presenting. But I was wondering because usually you receive total thyroidectomy for maybe thyroid cancer.
Yes,
Okay.
yes.
Yeah, like you suggested. But if such a study is going to be done as to the how soon patient with subthyroidectomy will develop hypothyroidism, and then the incidence is going to be, a follow-up study, and it's
Yeah.
going to take a very long time.
Long time, yes.
Yeah, so I don't know, although it's not impossible, after all, they do it in other places, so it's something that the society can actually look into. It's just to collect the number of people who have done or who are doing subtotal thyroidectomy, and then we'll tell them to follow them up maybe for the next
Oh,
3 years, 5 years,
yes, yeah.
and then see how many of them, you know, and they would develop hypothyroidism, and how soon they would
Hypothyroidism.
develop hypothyroidism. It's actually a feasible study, and it's something that I think can be done. Most of the studies we've been doing in Nigeria, they are never follow-up studies. We actually need some of them to be able to report our own experience. So
Yes.
I think it's something that can be done. So it's one of the takeaway points that I think we can pick from this presentation, that we can look at the incidence of hypothyroidism in patients undergoing subtotal thyroidectomy.
Subtotal thyroidectomy.
Yeah, so I think it's something that we can look into. Yeah. The other thing that
Let me add
I
something
look
to
at.
this before you go on, sir.
Okay.
Beyond there being a follow-up study, I think it can also be uh, retrospective because some of the patients that had surgery I know a woman that once presented to me. In her own case, she had developed hyperthyroidism again, and she had subtotal thyroidectomy. So I think we can look at uh, what it needs is to look at the hospital wherever we work. It will need to be a multi-center study. So we look at the cases that we have had. We may collaborate with the surgeons because most of these patients they do the thyroidectomy, and so we can look at the records apart from doing a follow-up study, which will help shorten the length of stay or length of the study.
Yeah, so I agree with you that can be done. A retrospective study can be done. It's just that, for a study like this, that was not specifically, issue that was not specifically set out when the surgery was done. And then with the way we store our data in this part of the world, most centers are still using folders
Paperwork,
rather
yeah.
than electronic. So that's just some of the challenges that one can experience when you are doing a retrospective study. But that does not mean it can't be looked into. Okay, it can be looked into. In fact, what people do now is you can actually merge a retrospective and prospective,
And
and
prospective,
then
yes.
yes. So it's something that can be done. Yes, so it's something that can be done. I think we can look into it. Yes, the last thing I was going to say was the dose of so that was given to this patient, 30 milligrams BD, that's 60
BD.
milligrams 60 milligrams per day, and I was wondering whether that dose was not on the high side. I just need a reference on that 60 milligrams that was given to the patient. But in all, it was a very good presentation. Well done to the zone.
Thank you. Well, it was difficult to get the young man to be euthyroid before the surgery. We had started with 15 milligram BD, and that you notice that the patient presented, or this whole journey started in 2024. In fact, at a time, we lost him to follow up. So that's actually why we had to go up to the 60 milligrams per day to see if we can achieve the euthyroid state for him to have the surgery, bearing in mind his cardiac complications. Okay, so in the absence of any other comments or question, I will say let's all have a wonderful good evening and a lovely rest of the day. So happy Sunday, everyone.
Happy Sunday to you, and thank you. Bye.
Thank you. All right. Bye-bye.